Hi guys, as part of your Unit 3 exam, I'm going to be talking about the peripheral artery disease of the lower extremities and peripheral vascular disease. We'll also talk about pulmonary embolism and DVT. I should apologize for the late submission of this PowerPoint presentation. I think Glenda mentioned to the class that I was working and I took care of a patient that had symptoms for COVID-19 and it turned out to be positive. But so we were all exposed. So right now I'm taking precautions to make sure that it doesn't transmit to the other people. So peripheral artery disease is the narrowing and degeneration of arteries of upper and lower extremities. It leads to decreased tissue perfusion. It mostly affects people in the age range of the 60s to 80s. But recently we've seen it in younger people just because of the diet and lack of exercise. It goes largely undiagnosed because it's very insidious. Some of the risk factors are atherosclerosis, coronary artery disease, brain attack, otherwise also known as severe diabetes and obesity. So these are some of the common sites of atherosclerotic lesions. Throughout this PowerPoint presentation, we'll be going through case study of BD as he progresses with this disease. This is a 62-year-old man, so he falls in the age group of 60 to 80. Complains of pain in his lower legs when walking his dog. But the pain is relieved when he takes rest. He has a history of hypertension and hyperlipidemia. So this predisposes him to cardiovascular illnesses, which includes peripheral arterial disease. He smokes 1 pack of cigarettes per day. That's another predisposition. So the clinical manifestations of PAD include intermittent claudication. So this is ischemic mass or pain that is caused by a constant level of exercise and results within 10 minutes or less with rest, and it's reproducible. So the pain at rest occurs in the foot or toes, aggravated by limb elevation. This is very classic of arterial insufficiency. So just be sure to not confuse this with venous insufficiency. And it occurs from insufficient blood flow, mostly arterial, occurs more often at night. It's also characterized by paresthesia, which is numbness or tingling in the toes of feet, produces loss of pressure and deep pain sensations. For the most part, when patient has an injury, it goes unnoticed because they have numbness, and so they don't know when they get injured. And this is further manifested by diminished or absent pedal popliteal or femoral pulses, pallor of foot with leg elevation, as you can see, this is in a dependent position, and then as soon as they elevate, the blood drains from the leg and causing the paleness. It is also characterized by thin, shiny, and taut skin, loss of hair on the lower legs because they're not getting the fresh blood or oxygenated blood that's pumped by the arterial system. And then reactive hyperemia of foot with dependent position, so otherwise known as dependent rubor, as shown in the picture. So as we continue with this case study, you're assessing BD. You find that his feet are pale and cool to touch. He has diminished pedal and posterior tibial pulses and decreased sensation. And he has a small open area on top of his foot. Note that this is an arterial ulcer, and we'll talk more about it as we go through the slides. This is very classic arterial ulcer. It's round. It's kind of like a punched out hole, which you'll see is completely different than venous ulcers. Some of the complications of PAD are atrophy of the skin and underlying muscles. Patient experienced delayed healing and wound infection because of poor circulation, tissue necrosis, and arterial ulcers, like I mentioned before. These are some of the characteristics of the arterial ulcers. Because of poor circulation, patient can end up with gangrene and necrosis on the distal parts of their extremities. So the description of the arterial ulcers is punched out bright red appearance, the wound edges are smooth, the shins are shiny, absent and decreased pulses, cool to touch, decreased cup refill, may lead to gangrene or osteomyelitis. Just for your future reference, make sure you know how to differentiate arterial ulcers from venous ulcers. Complications include non-healing arterial ulcers, and gangrene are more serious, may result in amputation if adequate blood flow is not restored, or if severe infection occurs. This includes osteomyelitis. So osteomyelitis is an infection that goes to the bone and sometimes can travel up the patient's extremity, and in that case the reason for amputation is to prevent further infection of the bone of the extremity. In these cases, patients are usually sent home on IV antibiotics, and so a PICC line will be placed or some form of central line, and patient is discharged either with home health, or patients are educated on how to self-administer IV antibiotics. The other option is for these patients to be sent to nursing home or SNF, skilled care nursing. Diagnostic studies, Doppler ultrasound, ankle brachial index. So less than 0.4 is a severe PAD. Then angiography, MRI, and duplex imaging. This is how to measure the ABI. And then we continue with BD's case study. So an angiography reveals nearly completely obstructed vessels in BD's lower extremities, and he's diagnosed with PAD. What treatment plan will you anticipate? We'll dive into that as we continue with the slides. So some of the things the patient can do is stop smoking, and then aggressive treatment of hyperlipidemia. Remember, hyperlipidemia is contributing to the atherosclerosis, and so we want to eliminate that. So LDL, otherwise known as bad cholesterol, needs to be lowered, and triglycerides needs to be lowered, and HDL needs to go up. BP maintained at less than 140/90, and for diabetic patients we want the hemoglobin A1C less than 6 to 7. And then of course for overweight patients we would like them to lose weight. Collaborative care, these are the ACE inhibitors that can be given, and then side effects. Just familiarize yourselves with the medication therapies and their side effects, and what teaching you'll provide to patients. One of the medications that hasn't been mentioned here is Plendale actually, and this medication has the same effect almost. It is a calcium channel blocker, and so anytime patient is taking Plendale, they should not be drinking grape juice or grapefruit because it will interact with the medication. So these are the drugs that the patient is ordered, and like I said, you need to provide teaching upon discharge. So exercise, walking is the most effective for individuals with claudication, and recommended is 30 to 60 minutes daily, 3 times a week. Diet high in fruits, and the fruit to avoid will be grapefruit, especially if they're on calcium channel blockers, and then vegetables and whole grains, and low in cholesterol, saturated fat, and salt. At the 3-month follow-up, blood pressure and lipid levels are stabilizing, but he continues to complain of leg pain at rest. His physician determines that it's time to consider an intervention to improve his circulation. And so these are some of the interventions. So if patient is having critical limb ischemia, intermittent claudication symptoms become incapacitating, pain at rest. If the patient is able to walk, and when they rest, the pain goes away, that is a good thing. But in this case, when they rest, the pain continues. So it's an indication that it is getting worse. So ulceration or gangrene, severe enough to threaten viability of the limb, will qualify the patient for surgery. And then also acute ischemia, which is sudden loss of blood supply, characterized by pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, otherwise known as temperature. And so just remember your 6 P's, and I'm circling this to make sure you get familiar with it. So bypass grafts are used to basically bypass the area of claudication as seen in this picture, and then also this one. So patient undergoes bilateral PTA with stenting. This is percutaneous transluminal angioplasty. And then they put stents as shown in here. What goals will you develop for him post-operatively? So we can delve into that in a few minutes. And then what are your 3 priority assessments? When BD comes to the recovery area after PTA with stenting, he has bilateral dressings on his groins and his position supine. So your priority is to continue to monitor the 6 P's: skin color and temperature, capillary refill, presence of peripheral pulses distal to the operative site. This is very important to determine the success of the surgery. Sensation and movement of the extremity. Knee flex position should be avoided except for exercise. So remember your 6 P's, and it's even highlighted in red. So BD is being discharged home. What will you be teaching him regarding immediate care and precautions at home? What patient teaching is essential for him to help manage his disease? First and foremost, management of risk factors, which is smoking, lack of exercise, diet, and then patient is going to be on long-term aspirin and other drug therapy, so they need to be taught how to manage those. Importance of gradual physical activity after surgery, and then importance of meticulous foot care. These are some of the foot care tips that you can review. And then also review this question and come up with an appropriate answer, and so we'll use that. We're also going to talk about Buerger's disease, which is also it's a rare form of vasculitis characterized by acute inflammation. Redness and clotting of arteries and veins of hands and feet, loss of pulses, can cause critical limb ischemia or claudication, rest pain, non-healing sores or ulcers in the hands and or feet. So the risk factors are men less than 45, long history of smoking or marijuana use, and periodontal infection. My take on this is that with legal marijuana use in Sacramento, in 20 years' time, we're going to have a lot of men that are less than 45 with black fingers. So to manage these, they need to quit smoking, and they cannot use a nicotine patch or gum because we're trying to avoid nicotine completely. They need to be walking, protect limbs from injury, and then this is a medication they can take. Sympathectomy, which is the sympathetic nerve will be removed. Scratch that. Amputation. And then we're going to move on to Raynaud's phenomenon. It's the severe temporary narrowing of the arteries that occurs in response to cold or stress. Fingers or toes turn white, blue, and then red. Numbness, and may cause ulceration or gangrene. Patients should wear gloves when handling cold items. Avoid cold and stress. Wear warm clothes. Smoking cessation. Stop meds or food which cause constriction, e.g. caffeine, cocaine, pseudoephedrine, procardia, and calcium channel blockers, iloprost, can be used to manage this condition. So just to go back to this slide, just remember with this phenomenon, remember what the symptoms are and how to manage the condition. So we're now going to move on to peripheral venous disorders. These include varicose veins, stasis, dermatitis and ulcers, venous thromboembolism and post-thrombotic syndrome, edema, eczema, achy, heavy, itchy. So varicose veins, you all are going to school to be nurses, and one of the things nurses do is be on their feet for long periods of time a day. So my advice to you, when you become nurses and start working those 12-hour or 16-hour shifts, do yourself a favor and buy compression socks that will help prevent weakened valves that cause spider veins or varicose veins. And this is not only for women, this is also for men. At the same time, just remember to take breaks, utilize any opportunity that you get to have to sit down, and if at all possible, put your feet up to rest them. You deserve it. You've earned it. Trust me, you'll remember this one day. You'll be like, Sylvia said so. Stasis, dermatitis, and venous ulcers. This is shallow, superficial, irregular ulcers associated with pain, edema, infection, usually on the lower ankle, hemosiderin stain, which is otherwise known as coppering, lipodermatosclerosis, which is woody appearance, and the leg will be warm and you can see exudate. So see, the appearance of this ulcer is completely different than the arterial ulcer we saw before. This has irregular borders and it's more superficial, while the arterial ulcer was more round and it's had a punched out appearance with no irregular borders, but this one has irregular borders. Patient education with venous stasis is elevate legs whenever possible, exercise regularly, avoid standing or sitting for long periods when traveling, plan rest stops to exercise legs. This is very important, and anytime you're on a long road trip, always remember to get up, walk around to prevent blood pooling, and especially on long flights. Provide information about smoking cessation, that's important. Avoid heat and cold next to the skin and protect against insect bites. Moisturize skin with non-allergenic preparations. These are widely available in the hospital, and so you can make recommendations to the patient to that effect. If a topical wound dressing or compression therapy is being used to treat a venous leg ulcer, explain why and how they work to heal. Use of elastic compression stockings put on before arising from bed. So Unabut for venous stasis ulcers maintains 20 to 30 mmHg pressure, may contain zinc and calamine, change every 2 to 7 days. So the risk factors for venous thromboembolism include hypercoagulability, which is caused by hormones, smoking, or sepsis cancer. For hormones, think of it like, especially for young females that are overweight and smoke, and then they put on birth control pills. That can sometimes be but a very predisposed condition to getting a blood clot. Injury to the endothelium from surgery, trauma, chemo, or diabetes. And then venous stasis originating deep leg veins, iliac and femoral. So this could be anything from sitting for long periods of time. And then the next one, atrial fibrillation, because there's pooling of blood. Most of the time, patients who have history of AFib are already on anticoagulation, and it's important to monitor their compliance. And then patients with CHF and obesity. And pregnancy also can put you at risk for VTE, and immobility, which is very common, especially for hospitalized patients. Early mobility is very important, especially post-op, and then use of compression devices available in the hospital. So some of the signs and symptoms of DVT are the calf pain. Just remember that hormone sign is not a very reliable way to diagnose DVT. Calf is swollen, warm, and red. Edema, increased calf circumference in lower extremity, DVT. And then low-grade temp. So as a nurse, you can always measure the circumference and feel the patient's skin. And if the doctors haven't noticed that the patient is having this issue, you can make recommendations based on your assessment, and at that point, they can do an ultrasound. So the main goal with VTE is prevention. Have the patient ambulate 4 to 6 times per day. Compression devices and TED hoses. Leg pump exercises every 2 to 4 hours, and then anticoagulation, either heparin or Lovenox, depending on the patient. Nursing care of a patient with a VTE. The leg should be elevated for VTE in leg. Measure calf circumference bilaterally. Manage anticoagulation, heparin, and I mentioned Lovenox or Fragmin, then Coumadin times 3 months. Bed rest versus early ambulation. Just to go back to the heparin question, whenever a patient comes in with an acute case of blood clot, patient is normally put on heparin drip, and they are started on Coumadin while the heparin is running, and then once they reach the goal for the Coumadin, then the heparin will be stopped. The Coumadin takes about 48 to 72 hours to meet the targeted range, which is 2 to 3 times normal. And so just keep in mind that the patient will be on heparin continuous infusion, and Coumadin will be started while the heparin is on board, and then heparin is discontinued once Coumadin is in the 2 to 3 times normal range. otherwise known as the therapeutic range. Bed rests versus early ambulation. Ambulation decreases edema and pain and decreases recurrence of new VTE. In the old days, they used to say patients with a blood clot should be on bed rest so the blood clot doesn't travel, but new research shows that that's not the case, and so early ambulation is preferred. And then patient education is very important. At UC Davis, we have patients that just started on Coumadin. They have to watch a video, an education video, to familiarize with themselves with how to manage the Coumadin at home. And then most importantly, monitor for pulmonary embolism, because if that blood clot dislodges from wherever in the body it is and it travels to the lungs, it could be a death and life and death situation. Not death and life and death. So heparin is normally given sub-Q. There is no oral form available. The half-life is 1 to 6 hours. Patients on heparin and waiting to go to surgery can receive heparin until a few hours before the surgery because of the short half-life. Monitor platelets. This is very important. Whenever patient is on heparin, you need to make sure that the platelets are not dropping, and that's why there's CBC that's drawn every so often, just to make sure the platelets stay within normal range. Monitor for bleeding, and if it occurs, obtain a PTT. We are now using anti-X-ray to monitor a therapeutic range for heparin infusion. Long-term use of heparin causes osteoporosis. Venous thromboembolism prophylaxis is 5,000 to 10,000 units every 6 to 12 hours. The practice at UC Davis is every 8 hours. And make sure you know what the antidote is for heparin. Lovenox is a low molecular weight heparin. It's only given sub-Q and no lab tests needed. It's given in the lab handles only. It's shorter acting and can be given up to 12 hours prior to surgery. Comes with pre-filled syringes with variable doses. Air bubble acts as locks. So when you're giving a Lovenox injection, be sure not to dispel the airlock. And this is also approved for home administration. That's what a Lovenox syringe looks like, and it always has an airlock at the beginning. And so the way this syringe is designed, it has a cell safety mechanism built in. When you give the injection, make sure you're holding on the phalanges, this part right here, and when you press, the spring will retract the needle back into the casing of the syringe. And then you can dispose it in a Sharps container. Fragment is also another low molecular weight heparin. Blood testing is not required. Peaks in 4 hours after administration. Teach how to inject. Monitor for bleeding. It's given almost like Lovenox. I haven't seen this in a little bit. We mostly give heparin and Lovenox. These are some of the injection sites you can give. Coumadin, good old Coumadin. This is for long-term coagulation, prevents further clotting, peaks in 36 to 72 hours. Some other research says 48 to 72. The key thing is I want the INR 2 to 2.5 times the normal. I mentioned earlier 2 to 3, but 2 to 2.5 is the recommended. Reversal agents include vitamin K and FFP. So vitamin K is most commonly used. Oh, I have to go back, sorry. Vitamin K is the most commonly used. FFP in cases of emergency, like say patient comes in and they've been in a traumatic situation, say motor vehicle accident, and they've been taking Coumadin. We don't have time to wait for the vitamin K to kick in, and so FFP will be infused during surgery or right before surgery. A lot of drug interactions with Coumadin. You know how we tell you to eat green leafy vegetables? With Coumadin, we say stay away from green leafy vegetables. The major side effect is bleeding. Teach patient about the diet restrictions. And it's Coumadin. So bleeding assessment, hemorrhage, epistaxis, which is nosebleed, bleeding gums, hematuria, GI bleeding, new onset headache, hematoma formation, electric razor, and soft toothbrush are the preferred methods for people who shave on a regular basis. Avoid alcohol, aspirin and NSAIDs. Oh, there it is. Avoid dark green leafy vegetables while taking Coumadin. Monitor lab tests. I think now there's a way for patients to monitor Coumadin levels, INR levels at home. Avoid herbs that decrease clotting, which include garlic, fish oil, ginger, green tea, and many others. I think we all know what that is by now. That is an arterial ulcer. It's punched out, it's round. And that's a venous ulcer. So is that. This is most likely due to arterial insufficiency, and you see the basically this toe is dying because of lack of circulation. That is a diabetic ulcer. There's no edema, no exudate. Plantar surface, heel or pressure points, round, colors, often painless. It's round, it's punched out, so it is arterial. So patient education for venous versus arterial. So remember, for arterial ulcers, we do not want any, for PAD, we don't want any compression therapy, no elevation. There are medications you can give. Possible surgical intervention to establish circulation, measure ABI. Some research says every 2 to 12 months, but most doctors do every 3 to 12. And definitely stop smoking. Compression therapy, use I don't know how to pronounce that, but that's a form of compression. Pain control, Leg elevation, remember venous elevate, arterial do not elevate. Exercise, calf, palms, ankle, range of motion, assess the skin daily. Lotions, measure ABI, keep 3 to 12 months, and stop smoking. I believe we no longer have D2L, so it is in canvas. End of slideshow.